Hello, everyone. My name is Megan Glenn, and I'm the National Assistant Director of Programs at the American Liver Foundation. I would like to welcome you to today's webinar. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease and their families through education, support, research, and advocacy. I would like to thank Dr. Bajaj, who will be sharing his expertise on today's webinar, and thank you to Kaleido Biosciences for the generous support of this webinar. Let me just start with a few housekeeping items. On the upper right-hand part of your screen, you should see a dialog box. If you don't see it, there's an orange arrow you can use to expand that window. From here, you can ask questions. You can ask questions at any time, and we'll be answering them towards the end of this webinar. We will get to as many questions as possible, and we do welcome your participation, so please do send in your questions. I would now like to introduce Dr. Bajaj. Dr. Bajaj is earned his master's degree in epidemiology, is active in research, and Dr. Bajaj has served as the principal investigator and co-investigator for numerous clinical trials in hepatic encephalopathy, chronic liver disease, and microbiome. Dr. Bajaj's research has been funded through the NIH, HRQ, ACG, and Veterans Affairs. His work has been published in Nature Gastroenterology, Hepatology, the American Journal of Gastroenterology, and Liver Transplantation, among other journals. Dr. Bajaj is Associate Editor for the American Journal of Gastroenterology and is on the editorial board for Hepatology, Journal of Hepatology, and Liver Transplantation. Dr. Bajaj frequently presents his work nationally and internationally at meetings, grand rounds, and symposia. He is a member of the Hepatic Encephalopathy Guidelines Writing Committee. He is also a fellow of several medical associations, including the AGA, ACG, AAFLD, and FRCP in London. He was elected to the American Society for Clinical Investigation. Dr. Bajaj was the chairperson of the Acute on Chronic Liver Failure Special Interest Group at the AAFLD and is a past president of the International Society for Hepatic Encephalopathy and Nitrogen Metabolism. He is the chair of the North American Consortium for the Study of End-Stage Liver Disease and currently works at the Division of Gastroenterology, Hepatology, and Nutrition at Virginia Commonwealth University and McGuire VA Medical Center in Richmond, Virginia. Dr. Bajaj, I will give you the floor.
Thank you so much, Megan, and thank you to Kaleido. Let's dive into. This is a little touchy, so if this goes back and forth, please forgive us. What is the questions that we need to ask? Why is it relevant to study microbial change in liver disease and cirrhosis? Is cirrhosis a gut microbial disease? And if so, what is lacking in our current microbial therapy for liver disease? And last but not the least, the most important question, can you manage cirrhosis completely only by treating microbiota? So before we go further, let's talk a little bit about what are the microbial analyses and outputs that you should encounter and you will encounter in your readings nowadays. So first, this is the phylogenetic tree of life. The green is the bacteria, the yellowish is eukaryotes, and archaea, which are older sequences, older microbes that are methanogens, are in the purple. And you can see the microbiota, these are the phyla, which is the highest, the most crudest way of defining the bacteria. In the human gut, there are proteobacteria, firmicutes, bacteroidetes, Voyarchaea, microbiota. Then you have fungi. And here are all the animals. So what it tells you that the microbiota that we have in our cells are much more complicated than our cells themselves in terms of diversity. And this is how we actually would describe E. coli in multiple taxonomy. So you have the phylum Proteobacteria, class Gamma Proteobacteriales, order Enterobacteriales, family Enterobacteriaceae, genus Escherichia, and species E. coli. So when you're looking at a study, you want to make sure that you're comparing apples to apples. So phylum, which is the most crudest way of defining these things, is also the easiest to define. But you have, as you go further and further down into species and strains, it becomes harder and harder to get these represented, and you need a deeper interrogation. So what you want to make sure that if you're comparing two studies, that they have the same taxonomy. So if someone ends the study at Enterobacteriaceae and another study goes all the way to the species, then you want to make sure that they are you're comparing them adequately and not 1:1. So what are the other ways of actually refining microbiota research? The first and easiest way, which bug is present and which is absent. We do this in clinical practice using culture-dependent means. So if you have someone who comes in with a fever and you actually want to send their biofluids like the blood or the urine, and this is how you actually find out its culture. But the only few things can be easily cultured. Almost every bacteria can be cultured, but some of them are very fastidious and require a lot more work to actually be cultured. So therefore, you need to do culture-independent techniques using the 16S RNA, which is a prokaryotic RNA. So fungi, which are eukaryotes, will not be done with through this. They need an 18S. So 16S is for bacteria and archaea, and fungi is 18S. So you can find out what the microbes are, what their genes are, which is metagenomics, and then you have GI tract microbes, which is metatranscriptomic, metaproteomics, and metabolomics, which means what are these bugs actually doing. This is very important because many people have different bugs that do the same thing. So there's a lot of redundancy in bacteria in the way they interact with each other and interact with the host. So you can have different bacteria doing the same work in interaction with themselves or other bacteria and the host itself. So it's important not only to find out what bacteria are present, but what products they make and how they interact with the host. And last but not the least, you want to make sure that you circulate back to some kind of host state or outcomes. Otherwise, it becomes very hard for us to take it to the next level. These are the stages of chronic liver disease where where microbiota are potentially important. I'm talking a little bit more about the alcohol. And in alcohol, you can see you have alcohol misuse, and some people with alcohol misuse develop liver disease, and some people don't. Why does alcohol misuse happen? People have brain dysfunction, depression, post-traumatic stress, etc. That can lead to a whole lot of other things that can predispose someone to develop alcoholic liver disease. But we all know there are plenty of people with significant alcohol misuse who do not develop alcoholic liver disease also. Then once someone has alcoholic liver disease, it has the spectrum of steatosis and fibrosis, compensated cirrhosis, decompensated cirrhosis, alcoholic hepatitis, death, transplant, and of course, a lot of these patients also have hepatic encephalopathy as well as other issues that go along with this. So where all can microbiota be relevant in this situation? You can see it's almost every single aspect. So, and it's also important to realize that many liver diseases have alteration in their microbiota, the gut microbiota, way before the liver disease actually starts. So you can have microbial changes here, you can have microbial changes here, and you can have microbial changes even after liver transplant. So it is very critical to realize that patients with liver disease could have multiple other areas of microbial change that predate the liver disease, and some would say could actually potentially cause the liver disease. So moving forward, what is the relevance of liver disease, microbiota and liver disease even before someone reaches cirrhosis? The easiest and best way of figuring out is, remember I told you there are some people who do not develop alcoholic liver disease regardless of whatever they drink. And a tempting suggestion would be, do these people have different microbiota than those who ultimately develop liver disease? And the answer, unfortunately, is no. It's not as easy. So this is mean bacteroideaceae, which is, if you remember, ACAA is a family, healthy controls, alcoholic patients who are not drinking, and patients who are drinking but had alcoholic liver disease. And you can see they're pretty much overlapping with each other. What about non-alcoholic fatty liver, another disease in which there could be intestinal permeability changes and gut barrier difficulties way before someone develops cirrhosis? And this goes all the way from F0 to F2, and you can see there is a gradual worsening of the liver disease, of the microbial concentration, with the Bacteroidetes right here in the red, whereas the and Ruminococcaceae, which are the reverse. So what it tells you here, that microbiota change, but they're not change 100% of the time with the liver disease. And as in humans, you know, it takes months to decades, months, years to decades to form end-stage liver disease. So it's very difficult for us to know whether it's the chicken or the egg at that point. What about cirrhosis and microbiota? As we know, cirrhosis is the end stage of liver disease, which is a compensated phase and a decompensated phase. So when you talk about just the microbiota composition in patients with cirrhosis, let's see if this moves. You want to compare cirrhosis to healthy controls, and you can see there's a difference in the stool microbial composition. There is also a difference in the colonic microbiota composition. There's a difference in the ascites microbiota composition. There's differences in the small bowel. There's differences in the liver. So the entire gut-liver axis is abnormal as far as the microbiota is concerned, or I would say not abnormal, different compared to people who are healthy. What about other biofluids? When you actually do the analysis of patients with cirrhosis and their microbiota, it's not only the gut-liver axis, it's the serum, the skin, as well as the saliva that are impaired in patients with cirrhosis. Now, why is that the case? It is because cirrhosis is also an immunodeficiency syndrome. There are problems with immunoinflammatory changes, which may be more global than just the organs that form the gut-liver axis. So patients with cirrhosis, as we know, are much more prone to develop infections, but this may be part of the reason why all these bacteria that are not supposed to grow, which are supposed to be suppressed by the bile and the immune system, are now allowed to grow in all these systems. So therefore there's dysbiosis almost everywhere you look. And this is exemplified by the cirrhosis dysbiosis ratio, in which the good bugs, and by the good bugs, I mean the bugs that produce short chain fatty acids, the bugs that also produce things such as secondary bile acids, are in the numerator, and the Enterobacteriaceae, which includes the gram-negative rods such as E. coli, Klebsiella, basically the bugs that we do not like in our patients with cirrhosis, are in the denominator. So if you have a numerator that is good bugs, and the denominator that is small a, that is quote unquote bad bugs, a high score would indicate everything is okay, right? So then to look at the validity, healthy controls have the highest cirrhosis dysbiosis ratio, compensated outpatients a little lower, decompensated outpatients even lower, and infected inpatients the lowest. So there is face validity to this. So you can use this greatly oversimplified reduction of microbiota that can potentially be brought into practice and put them across the spectrum of liver disease. What about its stability? Over time, if nothing happened to this patient, over 6 months, it remains stable. What about if someone developed encephalopathy? It got worse. What if it actually could predict who got hospitalized? The answer is yes. What happened after liver transplant? It got better. So what it tells you that the microbiota could be biosensors or markers of the underlying liver disease, and they go hand in hand. But again, it does not tell you what came first, whether it's the chicken or the egg. We still don't know. We know they go hand in hand. Okay, let's move further. What about outpatients outcomes? You can have hepatic encephalopathy, as we know. This is the altered gut-liver-brain axis, and these are Faecalibacterium and cognitive tests. Faecalibacterium is a good bug. It's a bug that produces short-chain fatty acids, and in other conditions, including inflammatory bowel disease, it is absent. It is also absent in the colonic mucosa of people who have cirrhosis, and this was negatively linked with brain function as well as the MRI of the brain. By hospitalizations in outpatients can be predicted by hepatic encephalopathy by patients with cirrhosis as well, by the salivary as well as the stool microbiota. And as we're going to talk about a little bit later, if you have certain microbiota in the stool or saliva, it's much more likely that you're going to be normal as far as your cognitive testing is concerned compared to the others. Okay, this is taking a little while. What about inpatients? You can see outpatients are a little clearer, but inpatients become very messy. You can have, because there's so many other things going on. There are antibiotics, there's probiotics, there's the instrumentations, there's infections, etc. So in this nice study from Taiwan, they took people with acute episodes of hepatic encephalopathy and compared them to healthy controls, compensated patients with cirrhosis and decompensated patients, and they were able to figure out who develops a poor outcome or a good outcome before. This was actually something that confirmed prior studies, both from India, from China and our places and multiple places in the US, that were independently able to show that microbiota in patients who died, which are in the red here, cluster closer than microbiota in the patients who remained alive, which are in the blue here. And these specific microbiota in the patients who died belong to Enterococcus and other gram-negative bacteria, which are gram-positives, but are also something that we do not like in our patients, and other gram-negative bacteria that belongs to Pseudomonas, etc. So what it tells you that microbiota composition on admission can predict who dies, who gets acute and chronic liver failure, who is transferred to the ICU, and who ultimately lives to tell their tale in a few years or few months from now. So microbiota in cirrhosis is very, very important, the microbial composition, but what is again not clear, what comes first, is it the chicken or the egg? So this begs the question, is cirrhosis a gut microbial disease? Now, how do we answer that question? We can only answer that question by actually interacting with organisms that do not have any germs, because however many antibiotics we give to a person, their germs will always stay. So they never can be truly germ-free. So in this study that we did, we had germ-free mice with cirrhosis that we made cirrhotic using CCL4, and then we had conventional mice with cirrhosis and conventional controls. And this is the cerebellum, and this is the cortex. These IL-1B and MCP1 are inflammatory markers. IBA1 is a marker of microglial inflammation, and GFAP is a marker of glial inflammation, which tells you that these mice will likely have hepatic encephalopathy. The germ-free mice remain germ-free even in the cirrhotic stage. And what you can find here is the inflammation and the activation only happened in the mice that were cirrhotic in the conventional state. Sorry, this jumps forward and back a little bit, but were not present in the mice that were in the germ-free state, even though those mice had histological cirrhosis. So this tells you that the microbiota are critical for development of hepatic encephalopathy. Going further, what about when the microbiota and consequences of the changes of microbiota collide? So severe alcoholic hepatitis and no alcoholic hepatitis. So mice, germ-free mice that were given stool from people who had severe alcoholic hepatitis had a completely different microbial composition than those who had no alcoholic hepatitis. And this actually made it worse. So once the mice with the mice that were given stool from a severe alcoholic hepatitis person were fed alcohol, their extent of liver injury was significantly higher than those who got microbiota from people who did not have alcoholic hepatitis. However, when you actually did the analysis of their liver itself, the liver itself shows mild inflammation, but not something that actually got worse in the absence of alcohol. Again, this is a hint that microbiota may be complicit, but not totally causative. In this study that we had done, we took germ-free mice, and we humanized them with healthy controls, people who were cirrhotic but were not drinking, and people who were drinking, actively drinking as well. And then we sacrificed the mice at day 30, and this is what we found. The IL-1B serum and serum endotoxin of the mice were highest in those who got the mice, and you can see here, germ-free controls, healthy controls, and cirrhosis, patients with cirrhosis and alcohol-related cirrhosis who were actively drinking. There was a gradation of the serum in the mice who received this, same with serum endotoxin. Of course, serum endotoxin is a gram-negative rod product, so therefore it was absent in the germ-free mice, and it crept up, and bacterial translocation, defined as bacteria present in the mesenteric lymph nodes, were only present in the mice that were given stool from the people who were actively drinking in the setting of cirrhosis, but not in the other groups. What happened to their microbiota and their bile acids? Okay, this is taking a little while. So the cirrhosis and healthy, there were difference. Alcohol and healthy, there was a difference. And alcohol and cirrhosis, there was a difference. So basically, this replicated human results without alcohol intake. The functionality of the bile acids, which are right here, total, stool, we are not going to go over the details. But more importantly, the activation of the liver enzymes that produce bile acids and modify bile acids were pretty much tracking what the microbiota did in the intact human. Remember, these mice were not exposed to alcohol. So what it tells you is when you give germ-free mice microbiota from specific phenotypes of humans, they typically follow their cycle in there. But does this result in cirrhosis? The answer is no. It causes all these changes that the microbiota would do, but it doesn't really end up causing cirrhosis. So this is a summation of what happens. You have healthy stool donor, healthy human, non-drinking human with cirrhosis, non-drinking human with HE, actively drinking non-cirrhotic human, and actively drinking cirrhotic human. Basically, over whatever permutations and combinations you can think of. Obviously, if compared to a germ-free state, these mice have never seen microbiota before. There's increase in systemic inflammation, but the liver inflammation goes up only in those who got it from people who were doing something bad to themselves or had cirrhosis or were actively drinking, not in healthy humans. And liver injury and cirrhosis only happened when they were fed alcohol or some hepatotoxicity was also done. So what this tells you, long story short, is patients who the microbiota are complicit but not causative. So if you have a microbiota of something that actually results in bad outcomes for the patient and you give them the hepatotoxic medication or insult, this actually makes things worse. But on their own, they cause inflammation but do not cause cirrhosis. So moving forward to hepatic encephalopathy, a topic close to my heart and brain. The current microbial therapies require more precision because prebiotics, probiotics are not very good. But there are evidence that microbiota works very well because alterations with lactulose and rifaximin works in these patients. However, patients still get hepatic encephalopathy after this. And why does that happen? Is because it's changes in the gut, changes in the liver, changes in the kidney, changes in the stomach, in the skeletal muscle, as well as the brain, all conspire to cause these changes. And if you remember the mouse study, microglial activation and astrocyte swelling are big critical things that only happen in when gut microbiota are in there. So how do we operationalize the changes in cirrhosis and microbiota with this? So can we use the microbiota to diagnose cognitive dysfunction? The answer is yes. More importantly, you can actually find out who does not have MHE and why. Sorry, I'm going to move back a little bit. Because MHE is very hard to diagnose, we used it using 3 tests. And what we found is regardless of what test this patient used, if you had Ruminococcus and Clostridium cluster 14b, you were unlikely to perform poorly in any of these tests. Going further, what about diet? If you had a Turkish or a Mediterranean diet, you're much more likely to have good diversity. As you can see, controls, compensated and decompensated patients in the Turkish diet were similar, whereas in the American diet, which is the Western diet, things got worse as the patients got decompensated. And more importantly, the yogurt that they eat every day also protected them from hospitalizations. So this is another way we can harness the bacteria to actually make things better for our patients. Going further, what about the teeth? There's an alteration in oral gut liver axis. Long story short, after you cleaned people with cirrhosis their teeth, you found a reduction in the MELD score, reduction in endotoxemia, reduction in inflammation, and also changes in the salivary and stool microbiota. In a group that was not given this therapy, there was no change like this. In fact, the endotoxin got worse in these patients. So if a patient with cirrhosis comes to you, please open their mouth and see if they have any changes in their dental in their teeth. So if you can refer them to a dentist, you may actually be doing them a favor both microbiologically and systemically, and may potentially even help them clinically. So going further, fecal transplant, in this small study that we had done, we took fecal transplant from one donor who had the highest good bacteria. These are the bacteria who are in the numerator of the cirrhosis dysbiosis ratio. And this was a safety study, but to our surprise, we found that it actually had a clinical signal. And this clinical signal was not just in the microbial uh, composition, it was also the function. The brain function got better. The short chain fatty acids and the bile acids also improved. I'm going to race through this because I think we are running out of time. And it actually got better even when we did analysis with the, sorry, this is a little touchy, with the oral capsule. The similar design was used. The past one was in enema after antibiotics. Using oral capsules, the clinical outcomes were still good, and there were still beneficial changes in the lipopolysaccharide binding protein, duodenal microbes, and secondary to primary bile acid ratio. And what was very important is the secondary to primary bile acid ratio. If someone did not improve on this, things got much better. So it did not get better. So within 4 weeks, if this ratio does not get better, it is unlikely that this person's fecal transplant is going to last. So that is another way of figuring out how you can actually maintain therapy for these patients. And bringing it all together. So the first study that we did, which was the fecal transplant, we gave them antibiotics. After antibiotics, we gave them fecal transplant. So it was very difficult for us to find out whether the antibiotics helped those patients in the end, or was it the FMT donor material. Knowing our patients with cirrhosis who have such extreme exposure to antibiotics as well as PPIs, it is highly unlikely that those antibiotics actually help those patients, but we had no way of proving it except by doing these two things. This study, we took these patients who had received oral antibiotics, and this was their pre-FMT donor material. Then they got the FMT from the healthy donor, and this was their post-FMT donor material. Moreover, we wanted to find out whether it was the microbiota or the germ-free supernatant that caused it. So ultimately, we put these all into germ-free mice, and what we found is after antibiotics, but before FMT, there was a significant increase in brain inflammation and microglial activation in the mice that received this bug, these stools. But post FMT, this went down. So what it tells you that antibiotics made things worse for the patients with cirrhosis, and FMT actually quenched that in those patients. And the other important thing here was you need live bugs to do this. The germ-free supernatant did not do anything to the IL-1B, MCP1, or IBA, and they were pretty much similar to the germ-free controls. So ultimately, it tells you that this is the fecal transplant helps the brain function. It is not the oral antibiotics that are given before that. These builds take some longer time, sorry. So this is going to run forward. Sorry. So in summary, chronic liver disease is associated with alterations in gut microbial function and composition, which can propagate the liver disease process in the presence of altered systemic and local immune changes. Altered gut-brain axis is the main reason behind this. The microbial outcomes can diagnose and predict outcomes related to HE. Treatment focus on gut can help, but patients can still develop outcomes. There's a small randomized trials with an oral FMT as well as the enema FMT can do this. And these changes can be transmitted to germ-free mice post-FMT. But most important thing here is you cannot fix cirrhosis by just fixing the microbiota. So cirrhosis is not a gut microbial disease on its own. The microbiota are relevant, complicit, but not causative. So if you have a patient who is obese and does not want to control their diabetes but wants a probiotic to help them, that probiotic alone is not going to help. If you have a patient who continues to misuse alcohol, but then wants something you to give a fecal transplant to help them, the fecal transplant on its own is not going to help that patient unless it is also associated with alcohol abstinence from these patients. So I have a lot of people to thank, including you, for your attention, hopefully that you've been paying. But okay, now, sorry, go back. This is a very touchy. Can you go back to, yeah, there's many people here who helped, and many of them hopefully who are listening. And thank you all. And if there's any questions, let me know.
Thank you so much, Dr. Bajaj. We don't have any questions now, but if you do have any questions, please email education@liverfoundation.org, and we will make sure that we get those answered by Dr. Bajaj as soon as possible. So that's it. I want to thank you again, Dr. Bajaj. Thank you to Kaleido Biosciences for supporting this webinar, and thank you everyone for joining us today. And with that, we will bring this webinar to a close. Dr. Bajaj, do you have anything to add? Or?
No, thank you, and thank you to the ALF and Kaleido as well. And thank you all for listening.
Thank you so much.